Good afternoon, everyone. I would like to welcome you to today's webinar titled MACRA MIPS 101 for Health Coaches, Your Role in Maximizing Revenue Through Value-Based Payments. Today's presentation is brought to you by our Clinical Health Coach Learning Community, sponsored by the Iowa Chronic Care Consortium. And I'm your host, Amy Finstead with the Clinical Health Coach. As if there weren't enough acronyms in the language of healthcare before, we are now in the early implementation stages of MACRA. The Medicare Access and CHIP Reauthorization Act legislation signed into law in 2015 is changing the way providers and clinics are being paid. Today's webinar will discuss specifically how health coaches can operate effectively under MACRA, MIPS, and help boost your clinic's quality scores and revenues. Today's presenter, Dr. Don Klitgaard, is president of the Heartland Rural Physician Alliance. He will share what healthcare organizations and health coaches need to know about quality, cost, improvement activities, and advancing care information. As past medical director of a family medicine clinic and early adopter of patient-centered medical home, Dr. Klitgaard utilized health coaches as a key strategy in delivering patient-centered care. And in this presentation, he will crosswalk the health coaching functions with required quality reporting metrics. Learn how health coaching is evolving from a basic patient care service to a robust element in achieving optimal MIPS scores. So before I pass things off to Dr. Klitgaard, I would like to remind you that a recording of today's webinar and slide deck will be emailed out within the next 1 to 2 days. So without further delay, please welcome our presenter today, Dr. Don Klitgaard.
Hi there, everybody. Get my slides up here. So thank you for joining us for this webinar. Hopefully you'll find it both interesting and helpful in your roles, in your practices in your communities. This is just a little background on me. Don't need to know all of this stuff. Amy hit the high points. I'm a family physician, was medical director of a practice that went through early PCMH transformation about 15 years ago. Used health coaches in that role, introduced health coaches, population management, care coordination, chronic disease management kinds of things into our practice as part of that work. Have carried that on then as I do more work in the ACO world. Through Heartland Rural Physician Alliance, we have both a Medicare Shared Savings and a commercial Blue Cross Blue Shield ACO, and use a lot of the PCMH principles, including health coaches, care coordination, population management obviously is a key to that, and so we'll kind of get into some of that as we go forward. We are going to talk a lot about, cost and revenue and maximizing some of those things, but I just want you to know that I'm a clinician at heart, that as we talk through this stuff, while we have to pay attention to how that's going to affect payment, that's critically important for us to continue to be able to do our mission. My heart is always, I think, probably where a lot of your guys' hearts are. What can we do for our patients? How can we impact the health of our patients, the populations we care for in our practices and our communities? So today we're going to talk through in general, the transition from fee-for-service, which is kind of how we've always been paid in medicine in the U.S., to value-based payment. And MACRA and MIPS is a key part of that. We'll talk about the quality payment program. That's kind of how CMS is going about implementing the MACRA legislation. We'll go through the 4 main elements of the quality payment program that make up the MIPS score. So quality, cost, improvement activities, advancing care information, and how those are going to affect physician payment moving forward, how important those are. And then we'll talk about some examples too, not only of your role as health coaches in affecting that MIPS scoring and that, but as we look a little more broadly even in doing things better as a practice, health coaching's impact on that, how can you be engaged, or will you be engaged in both current fee-for-service opportunities for increasing practice revenue, doing the right thing for our patients that way, the MIPS score piece that we're just talking about there. And then as we move forward in other value-based payment arrangements, if you are already or may consider being in an ACO or other types of payment models, the work you do as health coaches is going to be integral to the success of a lot of those efforts. And so we'll talk through that a bit. So let's step back at the kind of 60,000 foot level here first and talk about what's driving some of those big changes. Just for a few slides here to kind of set the stage of why are we going through all this big change in medicine right now? Why are things being paid for differently? Why are we even having these discussions? One of the largest reasons for that, if you look at this slide kind of beginning in 1980, we were pretty expensive as far as the percent of our GDP, of our gross domestic product. How much of our national spending do we spend on healthcare? We've always been at the high end, but if you look back in the 80s, you know, we were roughly in line with many other developed countries, but you can see since then that big divergence of now we spend more than twice just about of any other developed nation in the world on the healthcare that we provide. And you can argue when you look at comparative data, there's some pretty basic healthcare things that even though we spend a lot more, we're not necessarily getting our money for our bang for our buck, the money for the dollars, or the care for the dollars that we were spending. So that's driving things. Obviously, that affects government, affects business, affects all of us in many ways. Only to get better as we go forward, right? So as you look at sort of that silver tsunami concept, I kind of like that, the baby boomers aging, and if we already have a Medicare system that is fairly high cost right now, where's that going to go? You can just see the numbers of number of seniors we're going to have be over 72 million by 2030, which seems like a ways away, but you can see this slide was 2009 to 2030. We're already a long ways through that, and so we need to get this figured out, right? We need to figure out how to provide better care at lower cost. And because of that, now over the last 5 to 10 to 15 years, there's been a lot of things tried and changing around how do we, in this case, deliver healthcare. So lots of transformational changes in the delivery of healthcare. So you think about the concept of the patient-centered medical home and what that means and how practices have implemented or adopted that. EHRs, prescribing, telemedicine, you know, disease registries, your role as health coaches. If you look back in outpatient medicine, you know, not too many years ago, there's been a big uptick in the use of health coaches, and as well as many of these other types of kind of structural changes to how we deliver healthcare, right, that have been going on. Similarly, lots of changes to how healthcare is being paid for. Per member per month kinds of payments. We'll talk in more detail about some of CMS's efforts to try and, even under a fee for service, encourage practices to do the right things, to spend more time, pay for more time spent, you know, with chronic care management or transitioning from one type of care to another. Lots of blended payment models of, well, we'll give you some money up front and some shared savings on the end and still a little bit of fee for service in the middle. So lots of different things being tried in the payment world. One of the biggest things, obviously, in addition to ACOs, which are out there, have been for the last 5 years or so in much more robust ways, but the whole MACRA, MIPS, QPP, that whole kind of series of changes and the rollout of that extensive payment change package by CMS, that one really is a game changer. That one is a huge change. It's by the biggest payer in the country. You know, in most places in the U.S., the Medicare population is a big, substantial part of the patient populations that we care for. And a lot of times what CMS does from a payment standpoint, private payers follow suit. Really, this is kind of the underlying core concept. You've probably heard many times about the triple aim, the whole idea of better care, smarter spending, healthier populations, those kinds of things, right? So how can we do this? How can we really functionally get this stuff going in practices? And in large part, you guys are the health coaching piece of this is a very important piece of this puzzle. And also we talk about the quadruple aim. So taking that same triple aim, but then adding in, if we make a system that does those three things, but in the process, we burn out our providers, we make it so that that system is unsustainable and unlivable for the majority of, be that primary care physicians or specialists or nurses or MAs or health coaches or front office people or anybody, you know, sort of anybody in that kind of outpatient, inpatient, clinician kind of roles. we've got to do this in a smart way that takes that into account. So really the value proposition is kind of what we're talking about. Whenever you hear that word value-based payment, well, it's tying payment to this concept of value. So quality over cost. So higher quality outcome, safety, service, better quality care at a lower cost. And you can see you can raise value by keeping quality about the same at a lower cost. You can raise value by improving quality at the same cost, or ideally where we're really shooting for is hopefully to increase the quality of the care provided on many levels, while at the same time looking at lowering cost in the process. So that's the biggest change in value. And just so you know where CMS's head is at in this is actually a CMS slide, not my slide, that they let me borrow, and basically it shows, kind of complicated, but the left half of the slide says where we're at right now, right? That's the current state. So there's those different categories, 1, 2, 3, and 4. And category 1 is kind of what we're used to, fee for service. Somebody comes in and sees us in the office, we turn in a super bill, we get paid X number of dollars for that office visit, boom, boom, boom. A fee for a service provided. And that's still the way that a large percentage of our payment from CMS and most payers in most areas is being generated at this point. There have been a number of efforts to link fee-for-service payments to quality, have to do some reporting around meaningful use, around PQRS, around some things that start to tie payment to quality in some way, right? That third category there then is now there's some alternative payment models. There's maybe some ACOs in the mix that start to, you still get paid fee-for-service in large part, but we start to think about other payments on the front end, like with CPC Plus, or shared savings on the back end, like a lot of the Track 1 ACOs or many of the other ACO models, right? And then you get to category 4, which is more the Medicare Advantage. You will pay you for taking care of a whole set of folks. So you can see that's current state. If you move to future state, that big orange bubble shrinks down to very little. There's probably always still going to be some fee for service, but more and more and more we have to take care of populations, get paid for differently for doing that. And so I imagine most of you as health coaches, as I as a physician think about what was I trained in, what am I comfortable with when it comes to providing healthcare, these kinds of things, this fits this is what I learned in medical school and residency, and what nurses have learned, and what we've thought about and talked about in clinics and hospitals over time, right? Most of these words kind of sink in and feel comfortable and hit home that this is what we do when we're providing healthcare to our patients. But more and more and more, we're getting asked to think about now other things, right? So part of our talk today is to kind of develop some comfort of how do we move from just talking about that last slide to talking about some of this stuff, right? So how is value-based payment? How does that going to work? What's risk? How does quality fit in? How are all those things? Where's our part in this? And so as we do that, lots of new acronyms like you heard in the intro, right? So in the CMS side, you've probably heard most of these acronyms being bandied around, right? And so this is last times I think how we feel, man, all these different things being talked about. So we're going to take a look at some of the important acronyms in this to try and make sure we all have a baseline understanding of it, and then tie that to what you do as health coaches. So what does MACRA really stand for? Some of the physicians that I talk to think that this is what MACRA stands for. It's not really about making us angry, although that does sometimes happen. It's the Medicare Access and CHIP Reauthorization Act, like you heard in the intro. So that's the piece of legislation that was passed by Congress that set up the stage for some of these payment changes to happen. Right? It was actually the most bipartisan piece of legislation in a very, very long time, the last decade or more, I think. So you can see it was not Republicans or Democrats pushing this through. It was really a very bipartisan effort. So the MACRA is the legislation piece that was passed in 2015. You'll hear less and less about MACRA and more about QPP. So that acronym stands for the Quality Payment Program. So that's the rules. That's the implementation of the MACRA legislation. So if we talk about, so what are we going to be held accountable to? It's the Quality Payment Program. Okay, so that's when you hear those terms. MACRA is the legislation, important, but probably will be talked about less and less, because the Quality Payment Program and the things that come out of that are really the things that are going to matter to us. So basically, MACRA and the Quality Payment Program kind of have two separate arms, right? So they're either falling under a merit-based incentive payment system. So that's MIPS. When you see the MIPS or MIPS score, those kinds of things, that's merit-based, meaning if you do better at certain things, you get paid better, you know, higher merit kind of stuff, right? Incentive payment system, we're going to try and incent docs and physicians and practices and systems to do a better job and pay them better if they do. And then there's advanced alternative payment models. So if you are in one of those, which we'll talk a little bit about, say an ACO that has some downside risk falls in that category, then you don't have to worry about the MIP stuff we're going to talk about. You have a whole different payment structure that you'll fall under. So we're going to spend most of our time, obviously, in the first half of that. So what does MIPS do? It really takes a lot of the programs that you may have had to deal with in some way, may had some interaction with meaningful use, value-based modifier payments, PQRS value or reporting of quality, those kinds of things. And it makes all of those, instead of being separate reporting systems, it kind of condenses all of those under the MIPS program. And really, it gives a composite score. So every physician in the US that's actively caring, there's a few exceptions, but the vast majority of physicians are going to get a score from CMS. They're going to now have a MIPS score by physician. Okay, the score is going to be from 1 to 100. Each provider is going to get their own score. There's a few instances where you can report as a group, and every provider in that group will get the same score. Every provider in an ACO might get the same score, but each provider is going to have a unique score. That score is going to be based on 4 categories: quality, cost, improvement activities, and advancing care information. So when you see advancing care information, think meaningful use. That's sort of the meaningful use stuff that we've been reporting on in before. Can you use, do you have a certified EHR? Can you report to registries? Can you do a certain set of things electronically? That type of stuff, right? Quality is going to be real important, especially for you guys, because you will probably play a significant role in the quality efforts in your practices, and some of the things that are reported as quality under MIPS will be things that you will be a part of. We'll talk about that. Cost didn't get scored as anything last year, but from this year going forward, we're going to be held accountable for the cost of the care we provide to a certain extent. That's going to be a component of the MIPS score. And then improvement activities. Improvement activities is kind of, think of it as quality improvement initiatives in the practice. So certain things you would do to improve the care that you provide. And a lot of times things around care coordination, better care of certain populations, diabetics or whatever, those kinds of activities may well involve the health coaches very substantially. And if we're doing things right, those improvement activities that you're going to get some points for here are going to improve the quality score, and they're going to lower the cost. So these things aren't, while they are different subsets of the MIPS score, they do often tie together, and we'll explore that a little more as we go forward. So in the first year, in 2017, which is the one we'll get our 2017 scores kind of halfway through 2018 here. So when we see our first MIPS scores later this year, this is the kind of how each of those 4 categories was weighted in that first year. They called it a transition year. 2017 was the first year that this was really being implemented. So quality accounted for 60% of the score. Cost wasn't accounted for at all. Improvement activities, 15%, and the advancing care information, 25%. That changes by year though. So if you look at this, that first column is performance year 2017. So that was last year. Those are the same numbers we just saw on the last slide. You can see as we go forward though, for this performance year, the year we're in right now, so the MIPS score that's generated for this year of 2018, 50% of that score will be based on quality instead of 60%. And now 10% of that score will be based on cost. Improvement activities and care, advancing care information stay the same. Going forward, starting next year and beyond, you can see the percentage of that score that is made up by the quality score goes down to 30% and then stays stable there. And cost goes up to 30%. And so quality and cost are kind of equally weighted when it comes to a final score. CMS does have some flexibility to be able to adjust those percentages. However, there was a lot of pressure on them not to include cost this year, that We weren't ready to do that yet. The provider community wasn't ready to take responsibility and be graded on how we do from a cost standpoint. But in the end, after all the feedback, CMS held firm and said, nope, it's going to stay at 10% and likely will stay at 30% for next year. So we just have to get used to the idea that even if we don't voluntarily sign up for an ACO or some kind of payment system that holds us accountable for cost, now we're going to be held accountable for cost, like it or not, from Medicare. So we have to kind of get our minds around what that means and get used to dealing with that. So what's that going to do to payment? So this slide tells us about how the payments are going to be adjusted based on the scores that are given. So every physician gets a MIPS score. Those are averaged across the practice, those kinds of things. And so the payment to that physician, I guess to be more precise, the payment to that physician will go up or down by a certain percentage, right? So the score that a individual physician got in 2017 will affect their payment in either a positive or negative way 2 years later in 2019. So if I did really well on my MIPS score in 2017, my payment might go up as much as 4%. If I didn't report and didn't do much of anything and I did a kind of a lousy job and got a very low MIPS score in 2017, my payment could go down by 4%. So for every claim that I turn in, what I would have gotten paid goes down by 4% or up by 4% on the other side. And you can see they've kind of ratcheted up kind of turned the heat up a little every year, right? So that the score from this year in 2018 will come into play in 2020 and our payment can go up or down by 5%, 7%, 9% in the years to come. So they give us a little bit of lead time to try and learn about this stuff and get good at it and figure it out. But pretty quickly, the impact that it has on payment goes up pretty substantially. So trying to pull all that together, you'll get a MIPS score. Each physician will get a MIPS score. Each practitioner will get a MIPS score. That score will be from 0 to 100, okay? There's going to be a performance threshold, so that middle line. So every year CMS will determine what's the kind of the threshold, and if you're above that threshold, you will get a positive impact on your payment. If you're below that threshold, you'll get some type of negative impact. And so where they set that bar is going to change from year to year. There's also a lower end. If you're below the 25th percentile, you're going to get the maximum negative adjustment, because this is a budget neutral situation, meaning that everybody that gets a positive adjustment, there's going to be the same number of people that get a negative adjustment. They're not adding money in or taking money away by doing this. They're keeping the pool of money the same, but redistributed it based on quality. That makes sense. There is some extra money sort of in the pot, so to speak, that they've been put in, about $500 million for what they're calling exceptional performance bonuses. So if you do a really good job and you are above that exceptional performer bonus category, you can share in an additional bonus. So in addition to the 4% increase, you may get a significant increase above that. So the performance threshold for last year was set very low. Like we said, the score goes from 0 to 100. They set the bar at 3. So basically, if you reported anything at all, most likely in 2017, you will not get a negative adjustment. Now, if you just did the bare minimum, you may not see much of a positive adjustment, but at least you'd stay about the same, right? Now, because they can change that yearly for 2018, they've now set that at 15. So it went from 3 to 15. So it's still not 50. It's not halfway between 0 and 100, but it did creep up quite a bit from 3 to 15, and we'll see kind of how that plays out. And you can see the score they set to reach that exceptional performance bonus is 70 out of 100, okay? So that's kind of the MIPS program for folks that aren't in any kind of alternative payment model. So that's if you're not in an ACO or CPC plus, any other kind of payment, structured payment system through Medicare, any kind of thing like that, then that's how payment is going to be affected from now going forward. Basically, last year was the first performance year. The payment change will take place in 2019. So beginning in January 2019, the payment will go up or down based on last year's score, and then sequentially going forward like we showed there. So that's really the MIPS piece of it, and sort of the structure of how that score is going to change payment, just so you kind of have that in mind as we talk forward now of how you can see how important it is to score well, right? And so your role in helping to have a good MIPS score for your practice is going to be critically important to payment going forward. Similarly, there are alternative payment models now. So there are two main categories of alternative payment models. Some of them are what are called MIPS alternative payment models. So this is things like a Track 1 ACO. So that's what most people that are in an ACO with Medicare, the majority right now are Track 1 ACOs, which means there's no downside risk to it. If you do a good job, you can get some shared savings. If you do a lousy job, CMS isn't going to come after you for anything. So it's kind of a no downside risk model. There are some other innovation models and some things that they've put out there as far as demonstration projects that fit under this category as well. If you're in one of those, and you don't have what they call a nominal amount of downside risk, which is sort of what you need to have to be in the other kind of payment model. So if you're in one of these, you're still going to fall under MIPS, but you're in one of these MIPS alternative payment models. And what happens is the scoring is a little different. The categories are the same, but the quality score only counts for about 50% of your score. And the only quality reporting you have to do if you're in one of these MIPS alternative payment models, if you're in a Track 1 ACO, is you just have to do your normal ACO quality reporting like you would have done anyway. And that meets that need, that checks that box for the quality score for CMS, and you'll get it, because you're already working on quality. That's part of the ACO model. Cost is set at 0 and will continue to be set at 0 because you're already being held accountable for costs through the accountable care organization, the ACO work you're doing. The improvement activities, so those are those things you're doing to try and improve things in your practice. The percentage of score, if you're in one of these, is 20%, but you automatically get 100% of that 20% just because you're in the ACO, because you're already they know you're doing work improvement-wise. You don't have to do any separate reporting or prove you've done anything different because you're already doing that work, and they're not going to make you jump through 2 hoops. And the advancing care information then stays the same as everybody else. So you can see the scoring is a little bit different, and the credit you get for the ACO work is very nice. So if you're in a Track 1 ACO or one of these other MIPS alternative payment models, you'll actually probably come out pretty darn good on your MIPS score. So there's some good benefit to being in one of these payment models under the MIPS scoring system. The other type of alternative payment model is something called an advanced alternative payment model, and that's one that does have a more than nominal downside risk. So if you don't do a good job and you spend more money than you were anticipated to spend on caring for these patients, you may be on the hook for paying some of that payment that you'd gotten up front back to CMS, right? So there's some what's called downside risk. So there are multiple Medicare shared savings ACOs, Track 1 Plus, 2, 3, Next Gen ACOs, those kinds of things for practices that are in the Comprehensive Primary Care Plus model. There may be some of those folks on the phone. If your practice is a CPC Plus practice, you're getting some upfront payment, but that's considered an advanced alternative payment model, so you don't have to worry about any of that MIPS scoring stuff, right? So all of these, though, and there's continually new ones being proposed and announced by CMS, those all require some type of downside risk. Now, because you've taken on a little bit of risk, though, there's some good benefits to doing that, some perks that you get that are the reason for practices doing that. Number one, you don't have to do any of that MIPS stuff and worry about, is my payment going to go up or down depending on my MIPS score. Instead of that, you get a 5% bonus. So as long as you meet a few criteria, you actually get a lump sum payment at the beginning of the year of 5% of what you billed Medicare in the performance year. So there's actually a pretty big carrot there to do one of these. And then down the road, you'll start to get some higher fee schedule updates. So we're going to stop there for a minute and turn it back over to the folks here before we go on with the second half of the presentation.
Thanks so much, Dr. Klitgaard. I'd like to take a quick break away from today's presentation to invite those of you joining us to visit our website at the conclusion of today's presentation at www.clinicalhealthcoach.com. Explore how coaching is transforming the conversations between providers and patients in hundreds of practices and ACOs across the country. Learn how coaching conversations are leading to improved outcomes and patient experience. We would love to explore how a coaching strategy may best fit and accelerate your practice transformation through one of our training solutions. We have a few of those outlined here on the slide in front of you. First off is our Clinical Health Coach Training Online, which is a self-paced online training program. It's about 26 hours. It's registration can be open for immediate start at any point. And again, it's self-paced and available on demand. It's a very popular training option. We also have our Fusion program, which is a combination of both our online and an 2-day on-site training. And we have an upcoming one slated sometime this summer in Clearwater, Florida. We will have more information on that coming out soon, and you can always check our website again. If you have more specific questions about that Fusion training, you can contact Kathy Kunith at iowaccc.com. Her information is there. And lastly is our on-site training. And this is a customizable training at your location, which works great for a lot of organizations that don't want to take their staff off-site. So again, there's a link to our on-site training overview with more information and questions that you may have. So now I'd like to kick it back to Dr. Klitgaard to continue with his presentation.
Excellent, thank you. So let's move then from, that's kind of the big picture stuff. So that's how we got where we got. That's sort of how MACRA and MIPS and quality payment program stuff works. Now let's spend some time digging into sort of what happens at the practice level and how do you fit in, how does health coach roles fit into some of this stuff. We'll start with a little discussion about patient-centered medical home, because that care model has really infused a lot of this directly and indirectly, right? So when we do our ACO work, a lot of what we're doing is based on a lot of the patient-centered medical home stuff. There's a little history of how things got to where we are now, and where patient-centered medical homes role is in that. When you read through the CMS and a lot of the other payers, what was the backstory? What's the thought behind a lot of this stuff? The ideas behind PCMH. So I'm not talking about you have to get NCQA or URAC certified as a PCMH. You can do that. Those aren't bad things. But what I'm talking about is kind of these things, right? What are some of the key elements behind that around access and care management and comprehensive care, team-based care, a lot of those kind of quality and improvement and measurement in the practice using HIT well, those kinds of things, right? So this stuff, while we don't always talk about PCMH as PCMH up front, that whole concept, and there's sort of a new invigorated discussion around what are some of those key concepts in primary care moving forward as well, and they include most of this kind of stuff, and they have more emphasis on things like team-based care and care coordination as part of that, and that's certainly where you guys are. When I do my ACO work, when we think about other types of value-based healthcare that we're involved in, those principles of PCMH really are foundational for the success of any of this kind of stuff. So if we're talking about MIPS, if we're talking about being in an ACO, all of those kinds of things. So like in the MIPS world, if you get a higher score, so if you do a better job on quality, if you do a better job on improvement activities and maybe working overtime on lowering some costs, those kinds of things in those buckets we just talked about, those improved quality scores, that credit for the improvement activities kinds of things, all of those kinds of things are going to be key to higher payment going forward and making sure that you're doing well as a practice, right? If you get PCMH recognition by one of those entities, you actually get credit for the improvement activity score. So if your organization is a certified or recognized patient-centered medical home, that improvement activity bucket automatically gets checked off like the Track 1 ACOs do, right? And certainly the efforts that you take to get there are going to improve scores across the board in several of those areas. Similarly, if you're in or thinking of being in an accountable care organization, in my mind, as running one of these or several of these, you know, the success of our ACO in large part depends on three things. You got to improve quality of the care that you're providing, you have to manage cost in the process, and you have to address the risk in the population that you're treating. So those three things are kind of fundamental things in value-based purchasing in ACO world. And so quality improvement projects, those kinds of things improve substantially if you have that whole kind of thought process around PCMH. A lot of the things that you do in the PCMH recognition process prepare you to deal with costs. So our practices that come into our ACO already having that culture of thinking about things differently and working through things differently, putting care management, care coordination, health coaching in their practices, looking at populations, be that diabetics or people who need immunizations or who need some type of preventive services, and approaching that with some type of health coaching or care coordination model, do so much better. So those skills and those things you are doing, those are going to be necessary skill sets for practices to do well in an ACO type model. Right, and then risk adjustment in large part is all about coding. So maybe not directly affecting you guys, but what codes are put on the super bills, and actually as we talk through care of complex patients, and as your practices start to get more and more skills built around caring for some of those complex patients and populations, you guys are going to be probably right in the middle of a lot of that kind of stuff, even if you're not necessarily doing the coding piece of it exactly. You're going to be directly involved in many of that. So really, you know, health coaching has direct applications to many of these, and indirect almost all of them, right? So those kinds of things. You may have heard this phrase before, because this is kind of about, you know, how do we get paid better and create some margin in a practice, and what's your role in that, right? So do you know who said this is the question. I would have thought maybe like this is Warren Buffett or Bill Gates or something like that, but this is a lady that actually coined that phrase, no margin, no mission. Her name's Sister Irene Krauss from the Daughters of Charity. So she was a nun, also though a pretty tough CEO and hospital administrator who understood that medical care is a business, so you have to worry about margin, but it's a business with a mission, right? We lots of times, we as physicians, lots of times probably you as health coaches, as nurses, as other care professionals, think a lot about patient care from that standpoint. This reminds us that we have to think at least somewhat about payment, and in order to have that margin to be able to care well for the patients and the populations that we're responsible for caring for. So just kind of keeping that concept in the back of our mind of, we're not doing this to become millionaires in healthcare, but we do have to at least recognize that we have to worry about that payment stuff. So to that end, you know, what are some ways that you guys are or can be paid for? You know, what are some of these kinds of things that are available now and going forward are going to be more and more important and available through MIPS and other payment models to support the work you guys are doing? So right now, there's several obvious ways that CMS has gone through and created some new codes, which many of you probably or may well be familiar with and working with and on in the daily work in your practices. There's chronic care management codes. Obviously, as primary care practices and physicians, we bellyached forever about how we spend a lot of time and effort in our practices caring for folks, providing care that wasn't face-to-face office-based care necessarily, but was very important, was essential for, you know, high quality care and keeping people healthy and out of ERs and all those kinds of things. So, you know, this is CMS's way of recognizing that, right, and having a mechanism to do chronic care management. And so a lot of this work is almost all that work is not physician work at all. That's you guys, right? That's good staff, good health coaches, good folks in the office that are doing most of that care management directly. Transitional care management is also often, you know, tied to health coaching roles. Do you know who those patients are that have been in an ER, that have been discharged from the hospital. You know, what is the process like in your facility to identify those folks, reach out to them, make sure they get in for appointments, have what they need, you know, those kinds of things. So a lot of practices, as they build out their transitional care programs around what do they do for folks that have been hospitalized or in the ER. A lot of that work involves health coaches or care coordinators as part of that, right? Many commercial payers, many state Medicaid programs have specific payments, similar in some ways or different in other times, but pay for care coordination in a variety of different ways. Obviously depends on which state you're in or which commercial payers you have in your market, what those look like. Sometimes there's a lot of opportunities for that. Other times there's less depending on your market, but knowing what those are and taking advantage of those care coordination payments can be very big for organizations. A lot of times there's incentive payments out there for enhanced quality and better outcomes. So that's certainly where MIPS has fallen. A lot of state Medicaid programs, a lot of commercial health plans have some form of that. Maybe that's an ACO. Maybe that's a another type of quality improvement kind of payment process. But those efforts, no matter where they lie, and they're different from payer to payer, but those efforts will include health coaches almost universally. The whole idea of getting folks in for appropriate visits, right? This is in a fee-for-service world. In large part, we're getting ready for all this value-based purchasing, but in large part, right now today in 2018, a lot of our payment is still based on fee-for-service. So how do we continue to do well under fee-for-service for now while we prepare to do better in the value-based purchasing? Well, some of that is just around proactive care. It's better care. It's getting people in for follow-up visits, for physicals, for labs, for immunizations, for other preventive kinds of services. And a lot of times health coaches play a huge role in this. And these are, again, not trying to get people in for things they don't need, but truly following recommendations, getting them in for the right stuff to keep them healthy. That improves quality, that lowers cost. In the short run, though, that's also a revenue driver, and that gets folks in the door and gets some the right kind of care provided. So that's important to think about in a fee-for-service world. And health coaching, you know, it's supports increased value-based purchase revenue indirectly in other ways. So we've kind of talked about the MIPS score. So improving the quality metrics under the MIPS score can have a big impact on the MIPS score, which then affects payment. Those improvement activity projects that are lined up underneath the MIPS score, those almost always have to do with either better chronic disease management, reaching out to populations for care that's not being provided. You know, those kinds of things all relate very directly to health coaching, but also drive increased MIPS scores, which you know, increase payment to the practice. On the ACO side of things, similarly, when you're in an ACO, you have to meet certain quality metrics. So if you're not in one of those, somewhat similar to the MIPS scoring, there are 30 plus quality metrics that we get measured on every year. And so as we look at that as an ACO, we look at which of those 30 are we doing well on, which are a half a dozen or so that we aren't doing as well on, that we should try and improve. And we develop improvement projects, quality improvement projects around that. So in our ACO, one of the first things we did to try and do well was to make sure every practice had the skill set of health coaching and that built into their practice. We don't provide it from the ACO level. We try and build it out in the practice. We think that's more effective. And then we say, all right, now we've got some improvement activities to work on, some things we need to do to work on this subset of quality metrics for our ACO. And so a lot of that work, some of it's engaging the docs and making some changes, the nurses in the clinic as they do things, but a lot of it is health coaching functions. And so those things are very important in improving our quality scores in the ACO, which directly affects how much of the shared savings we get back. And a lot of the things we work on, there's kind of this whole concept of higher quality care often is lower cost care. Now, sometimes we've just talked about, you know, getting people in for visits and some of that, you're actually creating revenue, which means there's some cost to the payers associated with that. However, most of those things also prevent a lot more expensive things from needing to happen. So most of the time, by doing all of these right things and getting people in for the right care at the right time, we're actually lowering cost over time. So that's kind of this higher quality care, often almost usually means lower cost care. And so we look for those opportunities to find synergy between improving quality and lowering cost at the same time. So some examples might be around follow-up visits like we just talked about. In CMS, it might be getting people in for their annual wellness visit, which has kind of been a little dicey thing sometimes, because that means different things to patients sometimes than it means to CMS, but it does mean an opportunity to get folks in and really talk through some of the things we haven't necessarily taken the time to talk through, make sure they get what they need. Whether that's screenings for cancers, the colonoscopies, mammograms, et cetera, immunizations, those kinds of things. Again, those align quality in the right way with cost. We talk a lot in our ACO and in our MIPS practices that we work with about quality being a team sport. So that whole idea of team-based care, of teamwork, of taking stuff off the plates of the physicians and the nurses doing the day-to-day care stuff, and making sure we're using all our staff and all our skills well. And so that's lots of times where the discussions around population management, health coaching come in, and how can we use our health coaches to their best abilities to use their skills and their knowledge and what they do the best. When it comes to quality improvement projects, so when we do those improvement projects specifically, we also try to design them so that they meet a lot of needs at the same time. So when you do a quality improvement project, you can do it so that everybody in the practice is learning how to come together as a team. How can you practice together? It's kind of like, if you're on a football team or a basketball team, this is the equivalent of, coming together for practice before the game, and how do you learn to work together and run the same plays together, and who does what part of that, and have clear roles and those kinds of things. And so we really look at this as skill building for practice teams of how do you do this kind of practice change stuff. You can offer CME credit for the physicians, CEU credit for the nurses or MAs, whoever needs that type of credit. By doing that project, you can line it up so that you also get credit for it at the same time. We're doing a QI project on colonoscopies and mammograms right now, that at the end of the project, our teams are all going to have gone through, how do you do this? How do you do a PDSA cycle? Our docs are going to get 30 hours of CME credit. Our nurses are going to get 30 contact hours of CEU credit. The docs will also get this Part 4 board certification credit. Everybody else on the team that doesn't need credit, so to speak, is going to get significant recognition and praise for their part in the work of doing that. And that's kind of an important thing when it comes to the QI stuff. Make sure if you're doing those projects in your clinics, if you're part of those, make sure to celebrate the wins, to get that information out there about how you've improved the care for your patients and what that's doing for your practices, because that's important. The MIPS improvement activities, then, in that same line, those align things well. So just like we talked about, when you do those quality improvement projects, that can happen as part of this MIPS improvement activity piece, right? So we'll circle back around to MIPS. The improvement activities parts counts for about 15%. If you remember back to those slides of the MIPS score, there are about 112 activities to choose from. If you go to the cms.qpp.gov, the website, if you haven't looked at that yet, it's an excellent website. I didn't used to be able to say that about CMS websites. Usually they were kind of painful to negotiate, but the QPP one is actually excellent. It shows all of the different things you can do, in this case for improvement activities, just like it does for quality. And you'll see on here, as you look down this list of subcategories of improvement activities, number 2, number 3, many of these things have very much to do with health coaching, very directly, right? Managing populations, doing care coordination. Many of the rest of these could also include activities that involve health coaches pretty substantially as well. And so when you see that MIPS score stuff, yep, the physicians get the score, but everybody in the practice, and especially the health coaches in large part, is going to be involved in the improvement activities portion of that score, as well as the quality portion of that score, because the idea really is to align quality with cost, because as we become more and more accountable for cost, We have to figure that out at the practice level. I was just going to give you an example of how we look at some of this in an ACO, because this is exactly the kind of stuff, even if you're not in an ACO, if you're in a practice and you're starting to be held accountable for cost under MIPS, you're going to have to do the same kind of work. And so let's look at how that works a little bit and how that might intersect with your day-to-day life. So for example, in an ACO, we find out, like many ACOs, that one of the largest drivers of cost, one of the big buckets is ER visits. So our goal is we're going to try and reduce ER visits appropriately, right? And not just keep people out of the ER, but if they shouldn't be there, if they don't need to be there, if we can take better care of them to keep them from needing to be there, that's what we're looking for. So how does that really happen? Well, number one, we get some better data about who's going to the ER. So we've had to line up ways to get communications directly from the ER. We get some of that information from claims data. So we find out that there's people we're taking care of that we knew about the 2 times they were in the ER in our community because we have direct access to that data. We didn't know about the 10 times they went to the ER down the road, where we don't get those reports as timely or at all. So you get some information when you're in an ACO, or as you start to look at things differently, to figure out who are those folks. And then you start to figure out, how do we do better care in the office? And that's where you guys come in lots of times, right? So instead of having a health coach that's concentrating on, maybe a chronic disease population of diabetics, you can look at it as of who are the folks in our practice that have been to the ER more than 2 times or 3 times or 5 times this year, right? And use the skills of a health coach, care coordination kind of person to address what's really going on with them. Make follow-ups, make phone calls, see what's happening. Lots of times, like with many parts of healthcare, social determinants of health are huge, and you guys are great at finding out about issues there, helping address those kinds of issues, because a lot of times those are the issues that are driving frequent ER visits on those kinds of things. So sometimes it's better communication with the patients and letting them know they can call the clinic first. They shouldn't just show up to the ER. There may be some cultural issues involved, but lots of times it's the health coaches in the practice that play a key role in allowing these kinds of programs to be successful. Okay. So just a real high overview of a few key concepts, and then we'll stop in time for a few questions. So really, when we look at moving to value-based payments, so whether that's under MIPS, whether that's under an ACO, whether it's under something else, what are some of those kinds of things? So we think about alignment. How do you align quality and cost efforts? So how do you take better care of your patients? How do you choose the things you're going to work on, or what you as a health coach is going to spend your time doing, and which patients you're going to spend your time interacting with to improve quality? And also keep in mind then how do we also lower cost in the process? How do we provide better care for people, and in the process hopefully lower the overall cost of healthcare in the process? PCMH, like we talked about, lots of practice transformation ideas and knowledge serve as a really solid foundation for these kinds of efforts. We have to start to get and use data a little differently. You've heard a little discussion so far, and it's a whole nother talk on what is all the data you get when you're in an ACO around cost and around risk adjustment and those kinds of things. Those are some data streams that start to give you some different information about the patients you're caring for. And more and more of that is going to come into play, where we're used to looking at the data in their EHR, but more and more we're going to have population data, we're going to have non-healthcare data, we're going to have other things to look at that's going to tell us about the people we're caring for, and help us to hopefully take better care of them. The whole concept of population health and getting away from just treating who's in the exam room and then comes in the door. We still need to do a great job of that. Doesn't lessen the need for that, but we need to gradually be spending more and more of our time in proactive, coordinated care, getting paid for that kind of care, right? And a lot of that will start to be more and more asynchronous and not people sitting in front of us in the practice. As a key component to that, exactly what you guys are involved with most days, I think, the care management, the care coordination. How do we use the data, empower our staff, organize our practices well to be able to do everything from wellness and prevention? That's kind of one end of the spectrum. How do we address social determinants and wellness and prevention and those kinds of things? to a middle ground of how do we take good care of people with chronic diseases, diabetes, COPD, the things that lots of times are struggles for folks from a disease burden standpoint, all the way up to that subset of really high cost, really complex patients. And do we have a role and do we use care coordinators and chronic complex case managers to manage those folks differently on the outpatient side as well. So this may be how you're feeling at the end of this. Sometimes when we talk MACRA and value-based payment and how all this stuff fits together, this is kind of how it makes you feel. So don't give in. Don't let all this stuff make you feel this way, because this is actually exciting stuff. This is good healthcare. This is the reason most of us got into healthcare, was to take better care of folks, and we're just going to have more and more tools at our disposal, more and more information that we can use, more ideas about good patient care, and hopefully more flexibility in how we provide that and get paid for that going forward. So just remember, when we kind of are struggling with all the complexities of everything that's going on, this isn't something that's happening at a specific time. This is a process. This is a learning process, an ongoing iterative process over time. So don't panic. You guys are going to be an important part of this process going forward as well. So I'll stop there and open things up for questions.
Perfect. Thanks so much, Dr. Klitgaard, for sharing a lot of really great information with us today. We already have received some questions, but invite you to continue to submit additional questions for our presenter. We'll get to those with time permitting. Feel free to post those in the chat box on your screen. So let's take a look at the first question. And it says, can I leverage my work as a health coach to impact more than one of the 4 categories by doing pretty much the same work? And then it follows to say, is there any one area of focus that this might offer the greatest opportunity?
So most certainly, I think we touched on this a little bit, when it comes to the MIPS scoring piece of things, if you are thoughtful and this is, kind of a practice level discussion and decision usually of what improvement activities are we going to look at, right? So if you haven't done that already, maybe looking at, the diabetics in our practice. We were just had an ACO call this morning that showed, what are the most common diagnoses of who's showing up in the ER for our practice, right? For our ACO, right? And hypertension and COPD and diabetes, and a lot of those are those things that we, need to be caring for on the outpatient side are a lot of times those things. So as you look at how do we take, for example, better care of our diabetics, you can create an improvement activity around following those closer, managing those better, getting them in for their follow-up visits. Most of the there's quality metrics tied to that. So by doing a better job caring for those folks, you're doing an improvement activity and getting credit in that category. You're improving the quality of the care you provide through doing that project, so your quality score goes up. And most likely in the process, and we found this in our PCMH work long before we were 10, 12 years ago, long before we had any thoughts of an ACO, we saw a 25% decrease in ER visits the first year we put health coaches in place in our office to manage our diabetics with a registry better. We saw a 25% decrease in ER visits and an 18% decrease in hospitalizations. That was just, we weren't doing anything special. We were just keeping people from falling through the cracks, doing good health coaching, making sure we were getting folks in, right? And so yes, I think that one activity, and you can do an improvement activity, but it's also improving the quality bucket. It's also improving the cost score going forward as well.
Perfect. Thanks so much. I think we have time for one more question, and I will add that if there are additional questions that pop up, Dr. Klitgaard's email address is located on the slide in front of you, so feel free to connect with him after the webinar. So our last question, how do I convince the physician who leads my team that health coaching is different from health education and that I need dedicated time to follow up on lifestyle and or social determinants?
Those darn physicians. I can laugh and say that because I am one, right? Yeah, so that I think is going to be easier and easier for you going forward. So that was always a struggle. Even doing our PCMH work, when we kind of had that thought process in mind, it was hard to devote resources like health coach time to truly addressing those. I think there is more and more and more evidence directly and indirectly all the time around the value of addressing social determinants of health, around health coaching in general and care coordination in general, and that is much more than just education, as the question talked about there. So I think there are a host of resources out there now that talk about that. Pretty much all of the literature in value-based purchasing talks about how you how do you improve quality, how do you lower cost, and much of that now is out in the public world and being put in the hands of medical directors and decision makers in practices as they're thinking about joining an ACO or being part of value-based purchasing. They're going to be challenged in ways they never were before to think about that differently, to invest in resources, and that's part of what these payment models are looking at, is how do we really put our money where our mouth is and invest in some of those resources. And when I look at it in our ACO, what's one of the best investments in practice infrastructure to do well in an ACO or any value-based purchasing model, it's health coaching. It's the work that you guys are doing. You need lots of other pieces in place as well, but the work you're doing is absolutely critical to a lot of the success of any of these value-based purchasing models. And so I think you're going to get less and less and less pushback over time. I mean, that's always going to be a struggle, until somebody starts paying very directly for some of that in a very robust way. But that battle is going to get easier and easier and easier to win going forward.
Perfect. Thanks so much, Dr. Klitgaard. This has just been a wonderful and very enlightening presentation today. And from all of us here at the Clinical Health Coach, thank you for joining. And as a reminder, a link to the recording of this webinar will be sent within the next day. And again, if you have additional questions, you have Dr. Klitgaard's email information. So again, thanks so much. This concludes today's webinar, and I hope everybody has a great day.